discussing how to do and what to do, but exactly when to do and what comes out of it. So rather than just the test itself, we'll try and see where we can apply it and try to learn from a test. So any test you do, you need to come up with it needs to answer a question. So that question needs to be answered, and that should change your management pattern. So no financial interests. The electrodiagnostic test that we routinely use in ophthalmology is the VEP, which would be the flash, the pattern, and the multifocal that is coming, although experience on that is limited. The ERG, which is more to rule out retinal disorders, the EOG and the ENG. So we just talk essentially on the VEP, which is the most commonly used test for neuro-ophthalmology. It measures the visual potential across the cortical processing in response to stimulation of the retina by any form of stimulus or the other. So it tests the integrity of the visual pathway from the retina to the occipital cortex, and the electrodes that are there on the scalp which pick up these electrical activity changes that are occurring in the brain. So you have two, you have the flash VEP and you have the pattern VEP. The flash is a flash of light, and the pattern shows a checkerboard pattern which is used as the stimulus. It is the test of choice when you're looking for optic nerve and chiasmal lesions. First on the flash is less sensitive. Essentially it's just checking the integrity of the visual pathway, and because of the high variability across the population, it doesn't tell us so much, but it has very low asymmetry. So if you're suspecting that there may be involvement of one eye as compared to the other, then that can pick up. So even moderate amount of asymmetry is a sign of a pathology, and it can be used in suspected functional or non-organic pathology. And the advantage of flash is that the chance of not seeing or ignoring the stimulus as there is in a pattern is not there. So in patients who do not have cooperation, who do not cooperate, or there are other optical factors like an anterior segment opacity, cataract, so you can get fair amount of information about the visual pathway by doing a flash. And it's a series of positive and negative waves, and N2, P2 are the most robust components that we're looking at. So they are the most predictable, and they give us the maximum information. So the N2 comes around, a negative wave comes around 90 milliseconds, and a P2 comes around 120 milliseconds. And the amplitude is the height difference between N2, the graph of N2 and the peak of P2. So there is an initial delay in inference as the myelination gets complete, and then by 1 year or so, 6 months to 1 year, you start seeing more closer to normal levels. The pattern shows you the alternating checkerboard, and it's essentially in the central 8 to 10 degree that you're getting this response from. And here there is a significant variability. So just within the patient itself, repeat test may give you some amount of variability, and it's affected by refractive errors. The attention, if the patient is not actually looking at the pattern and is looking elsewhere, the response will be different. Retinal pathologies, and of course malingerers. A flash is better for a malinger when you're suspecting a malinger, because the patient can actually defocus or not really look at the target, and then you get an affected VEP. The important thing we're looking at is an increase in the latency. That is showing us a visual pathway dysfunction. It is the most reliable abnormality and would be the least affected by technical and patient related factors. It is suggestive of major optic nerve disorders and really is not pathognomonic of optic neuritis, and can be, of course, it's most used in optic neuritis, but can be seen in compression, macular dysfunctions, even in a lot of neurological problems as we've been seeing, particularly Parkinson's disease. So that's what you are looking for, the latency of a pattern VEP. We'll just run through a few cases as we had used these investigations and try and learn how we could. So we have this 32-year-old male who came to us with sudden loss of vision in the right eye for the past 4 days, pain on ocular movements, the best corrected visual acuity is reduced in the right eye, there is a right afferent pupillary defect, the fundus is essentially unremarkable. So all these things that are classically looking at possibly a retrobulbar neuritis, that's what we're looking at. We'll discuss the disorder in detail, but that's what clinically the impression that we get. So to confirm that, we get the VEP done. It is helpful when you're not sure or when you have a doubt, but it obviously helps us even in long follow-up how the patient is improving besides the visual acuity. So you can see the VEP changes. Left eye has an amplitude which is normal. The latency is 107, which is more or less within the normal limits. The right eye amplitude is reduced. The latency is markedly increased. So you have 141 milliseconds, markedly increased. You're pretty sure that you have a retrobulbar diagnosis confirmed, and you treat accordingly. We have another 31-year-old male, sudden diminution of vision in the right eye, 15 days. Again, mild ocular pain and eye movements, mild headache off and on. You have 1/60 in the right eye and 6/9 in the left eye. There is a right afferent defect. Again, the anterior posterior segment is unremarkable. Again, your RBN is your diagnosis. But here what I wanted to highlight was that there is some left subclinical involvement. You can see the latency is increased than what would normally see. So, of course, color, contrast, as you would be evaluating in any patient of neuro-ophthalmology and optic neuritis, you would see certain involvement, subclinical involvement in the other eye. So it helps us to pick up subclinical involvement which may not actually be there. So again, VEP helps us in two ways. On follow-up, you can see that there is an improvement in the latency in both the eyes, right eye and the left eye. So there was a subclinical involvement that has improved over time. Initially, of course, we're using it for optic neuritis, but in multiple sclerosis, it was initially used in the diagnosis, but is now no more considered essential as far as your diagnosis is concerned, but it helps us in optic nerve involvement. The MRI and OCT currently demonstrate only structural involvement, and VEPs are telling us about the functional involvement, and therefore may have a role when we're trying to look at medications that are preserving function over time. We had this thesis at RP Center under Professor Menon, and we saw that there is subclinical involvement in patients who may not complain. So we had these patients with multiple sclerosis having increased latency in the VEP as compared to the optic neuritis, which of course was affected, compared to the fellow eye of the optic neuritis only patients and the control. So you can see that even in multiple sclerosis, you have an increased latency, you have subtle optic nerve involvement, although the patient is not presenting to you or complaining of visual disorders. These were patients who were following up in neurology and were actually referred as a part of this work for ophthal examination. So they didn't have clinical problems, but they had subclinical involvement. You have this patient of 24-year-old male who presented with trauma to the left forehead and sudden loss of vision. He complained in the right eye. So you had trauma on the left side, you have loss of vision in the right eye. Fundus was unremarkable. So is it right traumatic optic neuropathy, and how do you explain that? So that helped us because we did a VEP. You can see that the right VEP is affected, so there is right traumatic optic neuropathy, although the injury was on the left side. So I'll show the imaging of this patient also, and we saw the fracture line going from the left side to the right optic nerve, sparing the left. So that's why the left was normal and the right was affected. And initially we thought that this patient was actually malingering and looking for some medical legal advantages. I'll show the CT in the subsequent talk on imaging. So another patient, we had this IIH. We don't call it BIH anymore actually, and you can see it's atrophic papilledema. The patient was an atrophic papilledema. The decision to make was, do we intervene? Do we do something for this? We found that there is some VEP responses in both the eyes. We went ahead with optic nerve fenestrations, and the vision recovered to 6/18, although it was constricted fields, but it told us that there is some visual function that is there seen on conduction, and that gave us the confidence to try and do something about it, although it was all under very guarded prognosis. A 24-year-old male patient receiving ATT for some time had subacute visual loss, 6/18 either eye. Is it ethambutol toxicity? We do the VEP, the flash VEP. There is some delay, but it's not really telling us accurately. But the moment you do pattern, you can see severely affected pattern VEPs, again showing us that there is optic nerve dysfunction, and we promptly advise the patient to be off ethambutol and follow up. So detecting ethambutol toxicity is one of the ways, and one of the studies we had done. Just another case, a 1-year-old child not recognizing mother. Parents want to know, does my child see? How's the prognosis? Almost nil, we would say, in the long term. It helps us to overcome hysteria and malingering, and that helps us. But important to know, abnormal VEP in a patient labeled as hysteria, you need to investigate and make sure that that is there. So clinically, optic nerve disorders, measuring visual acuity in smaller children, malingering to identify potential in opaque media, and unexplained visual loss. ERG essentially talking about the multifocal ERG, where we had this patient of trauma, and he had a normal VEP, and VEP ERG was normal, but you can see the pattern ERG is severely affected. So this patient had a macular lesion, repeatedly referred for a mild temporal pallor, repeatedly to the neuro-ophthalmology clinic. Thank you.